Learn when time session. Criteria for polycystic ovarian morphology. एउटा रोटरड्याम क्राइटेरिया भन्ने छ जुन सेम हो युएसजीको आधारमा 1 होइन. अन युएसजी मोर देन एन्ड इक्वल टु 12 फोलिकल अनि यसको साइज चाहिँ लेस देन 1 सेन्टिमिटर एन्ड इक्वल टु 9 मिलिमिटर र यसको भोल्युम चाहिँ मोर देन 10 ml इन वान अर बोथ ओभ्यारी. र अरू दुईवटा क्राइटेरिया छ. दुईवटा क्राइटेरियामा नम्बर अफ फोलिकल चेन्ज छ, अरू सब सेम छ. एउटामा मोर देन 20 फोलिकल छ भने एउटामा मोर देन 25 फोलिकल छ. मोर देन 20 फोलिकल युरोपियन सोसाइटी अफ ह्युमन रिप्रोडक्सन एन्ड इम्ब्रियोलोजीमा छ भने मोर देन 25 एन्ड्रोजन एक्सेस एन्ड पिसिओएस सोसाइटीमा छ. म्यानेजमेन्ट अफ पिसिओएसमा फर्स्ट लाइन भनेको लाइफस्टाइल मोडिफिकेसन गर्ने हो, जहाँ चाहिँ हामीले ओभरवेट र ओबेस पिसिओएस फिमेललाई हाइपोक्यालोरिक डाइट प्लस ब्रिस्क वाकिङ गर्नुपर्छ है भनेर भन्छौँ. किनकि इभन 5% वेट लस क्यान लिड टु ओभुलेटरी साइकल. एडभान्टेज अफ वेट लस के हो त? डिक्रिज सेन्ट्रल फ्याटले गर्दाखेरि इट इम्प्रुभ्स द इन्सुलिन सेन्सिटिभिटी. अनि डिक्रिज सेन्ट्रल फ्याटले गर्दाखेरि इट इम्प्रुभ्स इन्सुलिन सेन्सिटिभिटी भने इन्सुलिन सेन्सिटिभिटी इम्प्रुभ भयो भने सेक्स हर्मोन बाइन्डिङ ग्लोबुलिन पनि इन्क्रिज हुन्छ. त्यसले गर्दाखेरि एन्ड्रोजेन फ्री टेस्टोस्टेरोन लेभल चाहिँ कम हुन्छ. अर्को भनेको रिजम्सन अफ ओभुलेटरी साइकल इन 5 to 10% फिमेल हुन्छ.
Weight loss has multiple benefits, especially for individuals with conditions like polycystic ovarian syndrome, PCOS, where insulin resistance and hormonal imbalances are often present. Let's delve into how weight loss can lead to improved insulin sensitivity and increased hormone binding globulin. 1. Improved insulin sensitivity. Fat and insulin. Adipose tissue fat secretes various substances, including some that affect insulin action. When there's excessive adipose tissue, especially in the abdomen, it can release larger amounts of these substances that promote insulin resistance. Decreased fat stores. As you lose weight, there's a reduction in the amount of adipose tissue, and thus a reduction in the substances it releases. This leads to an improvement in insulin sensitivity, meaning the body needs less insulin to move glucose into the cells. 2. Increase in sex hormone binding globulin, SHBG. Insulin and SHBG. High levels of insulin in the body, often seen with insulin resistance, can suppress the liver's production of SHBG. SHBG is a protein that binds to sex hormones, including testosterone, weight loss, and hormones. As weight is lost and insulin sensitivity improves, the levels of circulating insulin decrease. This reduction can then lead to increased production of SHBG by the liver.
In case of PCOS, weight loss can sometimes
restore regular ovulatory cycles. Excess weight can contribute to insulin resistance, which in turn can lead to elevated levels of insulin. High insulin levels can cause the ovaries to produce more androgens, like testosterone, which can disrupt the ovulatory cycle. When someone with PCOS loses weight, it often improves insulin sensitivity. This can lead to lower insulin levels, which may decrease androgen production by the ovaries. As a result, this can help restore a more regular menstrual and ovulatory cycle in some women. The percentage of women who experience resumption of regular cycles after weight loss can vary, but studies suggest that it's around 5 to 10%. Keep in mind, though, that while weight loss may help, it's not a guaranteed cure for PCOS or its symptoms.
PCOS को लागि ड्रग अफ चोइस चाहिँ ओरल कन्ट्रासेप्टिभ पिल हो. हामीले प्रोजेस्टेरोन पनि दिन मिल्छ, तर प्रोजेस्टेरोन सुड बी अफ 3rd or 4th जेनेरेसन. त्यहाँ लिस्ट एन्ड्रोजेनिक साइड इफेक्ट हुन्छ.
In the treatment of polycystic ovarian syndrome, PCOS, choosing the right type of progesterone is crucial, especially when it comes to managing androgenic side effects. 3rd and 4th generation progestins, like drospirenone and desogestrel, are often recommended because they have lower androgenic activity compared to 1st and 2nd generation progestins, like levonorgestrel or norethindrone. The lower androgenic activity is important in PCOS because the condition itself is characterized by elevated levels of androgens. Using a progesterone with lower androgenic activity can help alleviate some symptoms like hirsutism and acne, rather than exacerbate them. Additionally, newer generations of progestins have been specifically designed to minimize side effects, including androgenic ones, while still providing effective contraception and cycle regulation.
Contraceptive pill helps in regularization of cycle.
Exactly. Oral contraceptive pills, OCPs, are commonly used to regulate menstrual cycles, especially in conditions like PCOS. The typical regimen involves taking an active pill containing both estrogen and a progestin for 3 weeks, followed by a 1-week break. During this break, you'll usually have a withdrawal bleed, which mimics a menstrual period. The hormones in the pills help to regulate the menstrual cycle by suppressing ovulation and stabilizing the endometrial lining. This makes the menstrual cycle more predictable and can alleviate symptoms like heavy bleeding or irregular cycles. The 1-week break is generally included to mimic the natural menstrual cycle and to allow for a withdrawal bleed. However, some newer regimens even eliminate the hormone-free week to further minimize symptoms. Oral contraceptive pills, OCPs, contain synthetic versions of the hormones estrogen and progesterone, and they work in a few different ways to regulate the menstrual cycle. First, they suppress ovulation by inhibiting the secretion of follicle-stimulating hormone FSH and luteinizing hormone LH from the pituitary gland. These hormones are essential for the maturation of an ovarian follicle and the release of an egg. When their release is inhibited, ovulation doesn't occur. Second, the hormones in OCPs help stabilize the endometrial lining. Normally, the endometrial lining thickens and sheds in response to natural fluctuations in estrogen and progesterone. OCPs maintain more consistent hormone levels, preventing the endometrial lining from thickening to the point where it would normally be shed. This results in lighter and more predictable periods. So in summary, OCPs work by suppressing ovulation and stabilizing the endometrial lining, making menstrual cycles more regular and often alleviating symptoms like heavy bleeding.
So यो कस्तो हुन्छ त भन्दाखेरि ओसिपी हामीले मेन्स्ट्रुएसन भएको फर्स्ट टाइममा दिन्छौँ या विदिन द 5 डेजको साइकल दिन्छौँ 3 हप्तासम्म दिन्छौँ र 1 विक अफ होइन त्यहाँ चाहिँ अब 1 विक अफ गऱ्यौँ भनेपछि हाम्रो विड्रल ब्लिडिङ हुन्छ अनि त्यसले चाहिँ मिमिक्स नर्मल नेचुरल मेन्स्ट्रुएसन अनि फेरि हामीले डे फर्स्ट अथवा विदिन द 5 डेजको साइकलमा ओसिपी दिन्छौँ के हुन्छ यहाँ हामीले ओसिपी दियौँ एक्सोजेनस इस्ट्रोजन प्लस प्रोजेस्टेरोन दियौँ भनेपछि नेगेटिभ फिडब्याक मेकानिजमले गर्दाखेरि एलएच र एफएसएच घट्छ अनि त्यहाँ देयर इज नो नेचुरल इस्ट्रोजन एन्ड प्रोजेस्टेरोन होइन इन द बडी द लेभल्स अफ इस्ट्रोजन एन्ड प्रोजेस्टेरोन exogenous are high for 3 weeks and when stopped results in menstruation and he started again after she menstruate simple छ हामीले ओसिपी दियौँ एक्सोजेनस इस्ट्रोजन र प्रोजेस्टेरोन दियौँ भनेपछि नेगेटिभ फिडब्याक मेकानिजमले गर्दाखेरि नेचुरल एलएच र एफएसएच घट्छ अनि त्यहाँ कुनै पनि इन्डोजेनियस इस्ट्रोजन र प्रोजेस्टेरोन हुँदैन तर एक्सोजेनस इस्ट्रोजन र प्रोजेस्टेरोन हुन्छ अनि त्यो चाहिँ 3 हप्तासम्म हाई हुन्छ र त्यसलाई रोक्ने बित्तिकै देयर इज मेन्स्ट्रुएसन एन्ड इज स्टार्टेड अगेन आफ्टर सी मेन्स्ट्रुएट सो एस्ट्रोजन एन्ड प्रोजेस्टेरोनले एउटा फिडब्याक मेकानिजमको काम गर्यो अर्को प्रोजेस्टेरोनको मात्रै पनि काम छ इट रिड्युसेस द एन्डोजेनियस ल्युटिनाइजिङ हर्मोन इट लिड्स टु डिक्रिज एन्ड्रोजन अनि हेन्स हिर्सुटिजम इज ट्रिटेड
Giving exogenous progesterone can have an impact on the levels of endogenous luteinizing hormone, LH. Normally, LH stimulates the theca cells in the ovaries to produce androgens. In conditions like PCOS, where there's often an excess of LH, this leads to elevated androgen levels, contributing to symptoms like hirsutism and acne. When you administer exogenous progesterone, it provides negative feedback to the pituitary gland. This suppresses the secretion of LH, which in turn reduces the stimulus for the ovaries to produce androgens. As a result, you get a decrease in androgen levels.
र त्यहाँ भएको एस्ट्रोजनले के गर्छ त भन्दाखेरि नेचुरल इस्ट्रोजन त घटाइदिन्छ एक्सोजेनस इस्ट्रोजन छ तर इन्डोजेनस इस्ट्रोजन त छैन त्यही भएर इट लिड्स टु थिनिङ अफ द इन्डोमेट्रियम होइन इन्डोमेट्रियल हाइपरप्लेजिया इज प्रिभेन्टेड यसरी इन्डोमेट्रियल हाइपरप्लेजिया प्रिभेन्टेड हुन्छ सो पिसिओएसको धेरै काम रहेछ एउटा काम के छ भन्दाखेरि नर्मल मेन्स्ट्रुअल रेगुलाइज गर्ने होइन रेगुलाइजेसन अफ द साइकल अर्को काम के छ हिर्सुटिजमले प्रिभेन्ट गर्ने र अर्को काम के छ इन्डोमेट्रियल हाइपरप्लेजियालाई पनि प्रिभेन्ट गर्ने So, drug of choice for menstrual irregularity, oligoanovulation in PCOS, होइन oligoanovulation यो भनेको लेस देन 9 साइकल पर इयर हो सो यसको ड्रग अफ चोइस भनेको ओरल कन्ट्रासेप्टिभ पिल अथवा इस्ट्रोजन एन्ड प्रोजेस्टेरोन प्याचेस, न्यू प्याचेस इच विक, अथवा इस्ट्रोजन एन्ड प्रोजेस्टेरोन रिङ. सेम रिङ क्यान बी युज फर 3 weeks.
Estrogen and progesterone patches are a transdermal method of delivering hormones, and they can be used to treat menstrual irregularities in conditions like PCOS. These patches are applied directly to the skin and release a steady amount of hormones that are absorbed through the skin into the bloodstream. In a typical regimen, an estrogen patch might be applied and worn continuously, while a progesterone patch may be added during the latter half of the menstrual cycle. The patches are usually changed weekly to maintain consistent hormone levels. Just like oral contraceptive pills, the hormones in the patches work to regulate the menstrual cycle by suppressing ovulation and stabilizing the endometrial lining. They can also offer the benefit of a more steady hormone release compared to pills, which can be beneficial for some women. These patches can be especially useful for those who have difficulty with oral medications or who experience gastrointestinal side effects. However, they're not suitable for everyone, and their effectiveness can vary from person to person.
सो इस्ट्रोजन एन्ड प्रोजेस्टेरोनको प्याच चाहिँ न्यू प्याच हामीले विकली चेन्ज गर्न सक्छौँ. यो पनि 3 हप्तासम्म अन गर्छौँ, यानि 3 हप्तासम्म लाउँछौँ र 1 हप्ता लाउँदैन. अर्को इस्ट्रोजन एन्ड प्रोजेस्टेरोनको रिङ हुन्छ. सेम रिङ क्यान बी युज फर 3 weeks, होइन, 3 week अन एन्ड 1 week अफ. अर्को चाहिँ अल्टरनेटिभ हामीले दिन सक्छौँ यदि ओसिपी आर कन्ट्राइन्डिकेटेड. एभ्री 1 to 3 month इफ दे डु नट मेन्स्ट्रुएट, वेन दे डु नट मेन्स्ट्रुएट हामीले प्रोजेस्टेरोन विथड्रल दिन्छौँ. मेड्रोक्सी प्रोजेस्टेरोन एसिटेट डेली ओरल्ली फर 12 days दिन्छौँ. अर्को माइक्रोनाइज्ड प्रोजेस्टेरोन दिन्छौँ डेली ओरल्ली, यो पनि फर 12 days. This leads to menstruation, but it does not act as contraceptive. It do not help in relieving acne and hirsutism.
When oral contraceptive pills are contraindicated or not suitable for some reason, a progesterone withdrawal regimen can be used to induce menstruation in women who have irregular cycles, such as those with PCOS. Progesterone is given, usually in the form of oral tablets like medroxyprogesterone acetate, for about 10 days. After stopping the medication, a withdrawal bleed usually occurs within a few days, mimicking a menstrual period. This approach doesn't prevent ovulation or provide contraceptive protection, but it does help to shed the endometrial lining, reducing the risk of endometrial hyperplasia, which could potentially lead to endometrial cancer over time if left untreated. The treatment is generally repeated every 1 to 3 months for women who do not have regular menstrual cycles. It's a way to manage some of the longer-term risks associated with irregular menstruation. Progesterone withdrawal regimens primarily focus on inducing a menstrual bleed and reducing the risk of endometrial hyperplasia. They don't specifically address the hormonal imbalances that contribute to acne and hirsutism in conditions like PCOS. The root cause of acne and hirsutism in PCOS is often elevated levels of androgens. Progesterone withdrawal doesn't significantly lower androgen levels. It mainly works to shed the endometrial lining by mimicking the luteal phase of the menstrual cycle. Once you stop taking the progesterone, you experience a withdrawal bleed, but the androgen levels remain relatively unchanged. In contrast, combined oral contraceptives containing estrogen and progestin are often more effective for treating acne and hirsutism because they can suppress ovarian androgen production and increase sex hormone binding globulin, which binds free testosterone in the bloodstream. So, while progesterone withdrawal can help regulate menstrual cycles and reduce the risk of endometrial hyperplasia, it's generally not effective for treating acne and hirsutism.
असली कुरा के हो भनेपछि ओसिपी जुन कम्बाइन्ड ओसिपी हुन्छ एस्ट्रोजन र सिन्थेटिक फर्म अफ प्रोजेस्टेरोन त्यसले चाहिँ सिनर्जिस्टिकली एक्ट गर्छ टु इनिबिट पिट्युटरी रिलिज अफ लुटिनाइजिङ हर्मोन एन्ड फोलिकुलर स्टिमुलेटिङ हर्मोन. फोलिकुलर स्टिमुलेटिङ हर्मोन इनिबिट भएपछि ओभुलेसन हुँदैन भनेपछि लुटिनाइजिङ हर्मोनले चाहिँ एन्ड्रोजन प्रोडक्सन फ्रम ओभेरिजलाई रिड्युस गर्छ. अर्को यसले चाहिँ यसमा रहेको इस्ट्रोजनले इन्क्रिज गर्छ प्रोडक्सन अफ सेक्स हर्मोन बाइन्डिङ ग्लोबली which binds to and neutralize the circulating androgen. Hence, combined OCP are effective in reducing androgen level. Progesterone withdrawal therapy. यो एप्रोच चाहिँ हामीले प्रोजेस्टेरोन सिन्थेटिक एनालग दिन्छौँ टु इन्ड्युस विथड्रल ब्लिड. प्रोजेस्टेरोन दिने अनि त्यसपछि दिन बन्द गर्ने, अनि यसले चाहिँ विथड्रल ब्लिड गराउँछ. अब यसमा इन्सुलिन रेजिस्टेन्स पनि थियो होइन, एनोभुलेसन थियो. अब इन्सुलिन रेजिस्टेन्स, ड्रग अफ चोइस फर इन्सुलिन रेजिस्टेन्स भनेको मेटफर्मिन हो. यहाँ
The term off-label use refers to using a medication for a purpose other than what it has been officially approved for by regulatory agencies like the FDA. In the context of PCOS, metformin is an example of this. Originally designed as an anti-diabetic medication, it's frequently used off-label for treating various symptoms of PCOS. Metformin works by improving insulin sensitivity, which can have multiple beneficial effects in PCOS. These include weight loss, restoring menstrual cycles, and reducing hyperandrogenism. The improved insulin sensitivity reduces the ovary's production of androgens, which helps in alleviating symptoms like hirsutism and acne. It can also help regulate menstrual cycles by improving ovarian function and may lead to weight loss by reducing insulin resistance and the associated hunger or weight gain. So, while metformin was not originally intended for treating PCOS, its off-label use has proven beneficial in managing a variety of symptoms associated with the condition.
मेटफर्मिन इन पिसिओएस अफ लेभल युज भनेको हामीले बुझिहाल्यौँ. त्यसकोमा चाहिँ के हुन्छ, वेट लस हुन्छ, रिस्टोर साइकल हुन्छ, एन्ड लोवर हाइपर एन्ड्रोजेनिजम. यसको इन्डिकेसन भनेको पिसिओएस विथ इम्पेयर्ड ग्लुकोज टोलरेन्स, अथवा पिसिओएस इफ फास्टिङ इन्सुलिन इज हाई, अथवा पिसिओएस इफ एक्यान्थोसिस नाइग्रिक्यान्स इज प्रेजेन्ट, अथवा पिसिओएस विथ फ्यामिली हिस्ट्री अफ डायबिटिज मेलाइटस. यसको साइड इफेक्टमा मोस्ट कमन साइड इफेक्ट भनेको जिआई साइड इफेक्ट हो, हेन्स गिभन विथ मिल. मोस्ट डेन्जरस साइड इफेक्ट भनेको ल्याक्टिक एसिडोसिस हो.
The most common side effects of metformin are gastrointestinal in nature, including nausea, diarrhea, and abdominal cramps. To mitigate these effects, it's often recommended to take metformin with a meal. Meal usually refers to milk, but it's generally advised to take metformin with food rather than specifically with milk, unless otherwise instructed by a healthcare provider. The most severe, albeit rare, side effect is lactic acidosis. This is a medical emergency that happens when lactic acid accumulates in the bloodstream faster than it can be removed. It's more likely to occur in individuals with kidney dysfunction, liver disease, or severe dehydration. That's why it's crucial to assess renal function before starting metformin to monitor it regularly while on the medication. Metformin can cause lactic acidosis by inhibiting hepatic gluconeogenesis and increasing anaerobic metabolism. Essentially, it shifts energy metabolism away from glucose and towards lactate and other substrates. Normally, lactic acid produced in the body is converted back to glucose in the liver. However, metformin's inhibitory effect on liver gluconeogenesis reduces this conversion, leading to accumulation of lactate under certain conditions. Renal failure adds an additional layer of risk because the kidneys play a critical role in clearing both metformin and lactate from the bloodstream. In the context of renal failure, the kidneys are less efficient at excreting these substances, leading to their accumulation and increasing the risk of lactic acidosis. Therefore, it's crucial to monitor kidney function in patients taking metformin.
कसैले अरू केही इन्डिकेसन अफ मेटफर्मिन सोध्यो भने इन पिसिओएस होइन, यदि पोलिसिस्टिक ओभेरियन सिन्ड्रोम भएको मान्छेले कन्सिभ गर्छ भनेपछि बिकज अफ डिक्रिज लेभल अफ प्रोजेस्टेरोन देयर इज इन्क्रिज चान्स अफ एभर्सन. तर यदि हामीले मेटफर्मिन दियौँ भनेपछि इज युज्ड इन पिसिओएस प्रेग्नेन्सीको बेला there will be decreased chance of abortion and diabetes in pregnancy. Decreased chance of abortion and decreased chance of diabetes in pregnancy. But now it is not recommended for this indication. Recommended is in insulin resistance. Right?
The 75-gram oral glucose tolerance test, OGTT, is used to assess glucose metabolism and diagnose conditions like diabetes and prediabetes. For PCOS patients who are at increased risk for insulin resistance and diabetes, Regular monitoring is essential. The difference in testing frequency is primarily due to the level of risk. 1. In all PCOS patients, a biennial, every 2 years, 75 grams OGTT is often recommended as a baseline measure for assessing glucose tolerance, given the higher risk of developing diabetes in this population compared to the general public. 2. In patients with insulin resistance, these individuals are at an even higher risk of progressing to diabetes, so a more frequent yearly 75 grams OGTT is often recommended for closer monitoring. The aim is to catch any deterioration in glucose metabolism as early as possible so that interventions can be made promptly. Certainly, using a numerical system can be a helpful way to remember these diagnostic criteria for insulin resistance. Think of fasting insulin as 2 by 10, which gives you 20 millius per milliliter for fasting insulin. For the 2-hour postprandial insulin level, you could think of 5 by 11, which gives you 55 millius per milliliters. So it's 2 by 10 for fasting and 5 by 11 for postprandial, linking the numbers in a way that may be easier to remember.
Insulin resistance is defined as fasting insulin is more than 20 milli international unit per ml. 2-hour postprandial insulin more than 55 milli international unit per ml. So यसको लेभल याद गर्नको लागि insulin resistance is defined as fasting insulin more than 2 into 10 milli international unit per ml र postprandial insulin 2-hour postprandial भनेको 5 into 11 यानी कि 55 milli international unit per ml. अब 2-hour OGTT result हेर्ने non-pregnant female मा है.
Commonly used to assess how well the body metabolizes glucose. The numbers you've provided are often considered as general guidelines for normal glucose levels in a non-pregnant female during this test. 1. Fasting less than 100 milligrams per deciliter. A fasting glucose level below 100 milligrams per deciliter is generally considered normal and indicates that the person is not currently experiencing hyperglycemia. 2. 1 hour postprandial less than 200 milligrams per deciliter. A level below 200 milligrams per deciliter 1 hour after consuming the glucose solution is also within the normal range. Going above this may be a sign of impaired glucose tolerance or diabetes. 3.
तेस्रोमा चाहिँ 2-hour postprandial OGTT दिएर हेर्छौँ र लेस देन 140 मिलिग्राम पर डेसिलिटर चाहिँ इट इज नर्मल भनेपछि 2-hour OGTT इन नन प्रेग्नेन्ट फिमेलमा 2 आवरमा हेऱ्यौँ भनेपछि चाहिँ लेस देन 140 हुन्छ अनि यदि 1 आवरमा हेऱ्यौँ भनेपछि लेस देन 1 hour postprandial भनेपछि इट इज लेस देन 200 र फास्टिङ postprandial चाहिँ लेस देन 100 फास्टिङ postprandial के अरे फास्टिङ मात्रै चाहिँ लेस देन 100 1 hour postprandial लेस देन 200 र 2 hour postprandial लेस देन 140.
Correct. In addition to metformin, other classes of medications like GLP-1, glucagon-like peptide 1, receptor agonists, and SGLT2, sodium glucose cotransporter 2 inhibitors, are also emerging as options for treating insulin resistance in conditions like PCOS. 1. GLP-1 receptor agonists. These drugs, such as liraglutide, mimic the action of natural GLP-1, thereby stimulating insulin secretion in a glucose-dependent manner and suppressing glucagon secretion. This can improve insulin sensitivity and potentially aid in weight loss. 2. SGLT2 inhibitors. Examples include dapagliflozin and empagliflozin. These medications work by inhibiting glucose reabsorption in the kidneys, leading to increased urinary glucose excretion and lower blood glucose levels. Both classes offer the added benefit of weight loss, which can be particularly helpful in PCOS patients who are overweight or obese. However, it's important to note that these medications are generally considered second or third line options.
Natural glucagon-like peptide action.
Natural glucagon-like peptides, specifically GLP-1, play a crucial role in regulating blood sugar levels. They are released from the gut in response to food intake. Here's a breakdown of their main actions. 1. Stimulate insulin secretion. GLP-1 enhances the secretion of insulin from the pancreatic beta cells, but this occurs in a glucose-dependent manner, meaning it only stimulates insulin secretion when blood sugar levels are elevated. 2. Suppress glucagon secretion. GLP-1 inhibits the release of glucagon, a hormone that raises blood sugar levels from the pancreatic alpha cells. This action is also glucose-dependent. 3. Delay gastric emptying. By slowing down the rate at which the stomach empties, GLP-1 contributes to a feeling of fullness.
भनेपछि हामीले अदर इन्सुलिन सेन्सिटाइजर दिन मिल्छौँ, जस्तै कि ग्लुकागोन लाइक पेप्टाइड GLP-1 रिसेप्टर एगोनिस्ट दिन मिल्छौँ, र अर्को सोडियम ग्लुकोज को ट्रान्सपोर्टर 2 इनिबिटर दिन मिल्छौँ होइन। यिनीहरूले चाहिँ PCOS पेसेन्ट जसमा चाहिँ वेट बढिरहेको छ त्यसलाई वेट लस गर्ने काम गर्छ, र साथसाथै इट इज नट रिकमेन्डेड ड्युरिङ प्रेग्नेन्सी।